I'd like to welcome you to Courage to Change Recovery Partners Clinic here in Macedonia. My name is Brian. I'm the office manager. On behalf of Dr. Valenki, Dr. Mark Allen, and Dr. Rich Grzanek, I'd like to welcome any new or prospective patients to our facility. In way of a background, we evolved from a sister clinic in Columbus by the name of Clinic 5. It's a large clinic in the Grandview Heights, Upper Arlington area of Columbus near OSU. It has 7 physicians who work there, and the patient population numbers between 500 and 600 patients. Most of those patients come from southern and central Ohio. I felt that the northeastern Ohio area was underserved in terms of good quality Suboxone programs at an affordable price, and I persuaded Dr. Kerwin and some other individuals to try starting a clinic up here in Ohio. In way of the opiate problem and how it's been evolving in Ohio, since 2000, between 2000 and 2008, there's been a 300% increase in overdose deaths due to opiates. In 2010, there were 67 individual doses of various types of opiates for every man, woman, and child in Ohio. And that is not even taking into account the amount of heroin that's out there. Prescription painkillers account for 67% of the unintended drug overdoses in 2008. A conservative estimate that there are 4 deaths due to opiate overdoses in Ohio on a daily basis. I think that number understates the amount or the mortality rate actually in Ohio. I think many of the cases of heroin overdose don't get reported as being a result of an opiate overdose. In terms of treatments available for opiate addiction, there's primarily 3 options. There's abstinence-only programs such as NA. There's treatment in government-sponsored Methadone clinics, which involve going there on a daily basis. And then since 2003, 2004 roughly, with the advent of the Data 2000 Act, Suboxone has been available to treat patients on an outpatient basis. A lot of people kind of equate Suboxone with Methadone, and they don't seem to understand there are significant differences. Suboxone is what's called a partial agonist, and it's different from other opiates in that it doesn't stimulate a particular opiate receptor called a mu receptor, and when that receptor is stimulated, it causes the euphoria and the sense of well-being that all addicts were captivated with early on in their addiction. Suboxone does not stimulate that, and that's why it's called a partial agonist. It also has an opiate blocker called naloxone in it, which serves a couple purposes, which we'll talk about later. Because Suboxone is this unique partial agonist-antagonist, it's very safe. It has a ceiling effect, and all other opiates, the more you take, it's dose dependent. The higher the side effects like constipation or nausea or sedation. Suboxone is limited at around 16 to 21 milligrams. It has no further effect. And so it's virtually impossible to overdose on Suboxone unless you abuse certain other drugs in combination with it, which we'll discuss later. Methadone, however, is a very dangerous drug. It has increasing tolerance. It has a very long half-life, which makes it prone to accumulate in the body, and not uncommonly ends up causing respiratory depression and death, particularly in combination with sedatives such as benzodiazepines or alcohol. And frequently family members will ask, well, you're just substituting one drug for another. And I like to use the insulin analogy. Insulin is used to treat diabetes. It does not cure diabetes. It manages it. And if while you're on insulin, perhaps a type 2 diabetic, if they're exercising and losing weight, then they may be able to get off the insulin once they achieve the desired lifestyle changes. Suboxone's the same way. While you're on Suboxone, it's not curing you from being an addict. You're always going to be an addict, but you can be an addict in recovery. So while you're on Suboxone, if you're doing the recovery-related activities such as going to meetings, working a 12-step program, getting a sponsor, perhaps going to some counseling, learning how to live life on life's terms without chemicals, then at some point you'll be able to get off the Suboxone because you've addressed the reasons why drugs appealed to you in the first place. If you don't do those recovery activities, then you truly have switched one drug for another, and it'll be very difficult to get off the Suboxone. In terms of how long you need to be on Suboxone, most patients, it seems, need to be on it around 9 to 12 months for them to get enough healing of the brain and get rid of some of the excess opiate receptors that they're successfully going to be able to wean themselves off the medication. And the way that weaning process occurs, or why it occurs, when you're taking high-dose opiates, the brain sees this as being abnormal. All these opiates are swirling around in the bloodstream and the cerebrospinal fluid, and it says this isn't right, so it tries to think of it as a sponge to suck up those extra opiates, so it makes more opiate receptors to bind to them. Well, as you get those extra opiate receptors binding to the medication or the heroin or whatever, then that increases your tolerance. It takes more and more drug to occupy those opiate receptors and get the same desired effect. When you discontinue a drug, if you have a large amount of opiate receptors, then they're crying out. They want to be occupied. They want to be stimulated. And if they're not, you're dope sick. Another very important thing to understand about Suboxone is you cannot be on sedative type drugs, particularly the benzodiazepines. These are Xanax, Ativan, Klonopin, Valium, Cerax, Halcyon, Restoril, and also some of the other commonly prescribed sedating drugs such as Soma and Tramadol. All those cannot be taken in conjunction with Suboxone. Just a little bit about the DATA 2000 Act. That's the Drug Abuse Treatment Act of 2000. It's paved the way for outpatient Suboxone programs, and physicians who complete a course of study and submit a waiver application to the Substance Abuse and Mental Health Service Administration as well as the DEA. If they're approved, then they're entitled to treat addicts in an outpatient setting with Suboxone, and in the first year they're limited to 30 patients. Thereafter they're limited to 100 patients total. For that reason, it's kind of restricted access to care for patients. Most physicians who obtain a Suboxone waiver rapidly fill up their program. And in addition, unfortunately, a lot of physicians come in with unrealistic expectations, and when they find out what it's like to deal with some addicts who are in very early recovery, they just decide that it's not worth it, or their staff will say, we're not dealing with these people, you know, you're going to have to quit. And for that reason, I'd say around half the physicians who initially get a waiver will stop doing it after a relatively short period of time. And this even further makes it difficult to obtain care. Some of the typical side effects of Suboxone would be typical opiate side effects. Probably the most common would be constipation. Along with that, patients may have some sleep issues, particularly insomnia. If patients are on too much Suboxone, they may actually notice some daytime sedation. Also common would be headaches or flushing. Sweats are particularly common. And in rare instances, although I've never seen this, the literature does state that you need to be vigilant for the possibility of jaundice in some individuals, which would be yellowing of the skin. That seems to be extremely rare in my experience. In terms of dosing, Most patients here are initially treated with 8 milligrams twice a day. Some patients do well on a little bit less than that. Less is best in terms of getting off of Suboxone down the line. If you're able to get away with just 8 milligrams a day, it'll make it that much easier to wean yourself off Suboxone down the line. Some patients with extreme heroin or opiate addictions, where they're on large amounts of opiates, they may struggle for a week or two with Suboxone at 8 milligrams twice a day, and then as their brain adjusts to it, they do just fine. Cross addiction is a phenomenon that's extremely important to understand. If you use other mood-altering drugs with Suboxone, you're going to crave your drug of choice. So even in the absence of Suboxone, if you're just not using drugs but you're an opiate addict, if you go out to the bar or take a tranquilizing pill or some type of mood-altering pill or do cocaine or crack or ecstasy, and those are not your thing, you'll notice that you're craving the opiates. And many opiate and other addicts relapse in not understanding that this cross-addiction is very real. And a lot of people relapse on alcohol. And maybe you've gone out to the bar and had a few drinks and alcohol isn't your thing, but somehow you end up at the dope house or you're on the phone with the dope man. How'd that happen? Well, that's cross-addiction. And if you want to be successful at staying off opiates, you need to avoid all mood-altering drugs, including alcohol. Any type of addiction is a family disease. There's a lot of codependency. That means that the individuals who live with you have to develop bizarre coping skills to put up with you or us. And so that makes them just as sick as you. And if they don't get help for that, then it's going to be a lot of chaos and drama and strife at home, and it'll make it that much easier to recover. So it's important for the family to get either counseling or go to Al-Anon, which is a 12-step based program for the family of addicts. Just a little review of our policies and procedures, which you filled out, signed off on each of the policies when you did your initial paperwork, but just to reinforce it. We do drug testing, often not on the first visit unless your insurance requires it. Some of the insurances that require prior authorization want an initial drug test. But we almost always will drug test on the second visit. That's more important to me because we're looking to see if you're compliant